Good afternoon and welcome, everybody. Thank you for joining us today. I'm just going to give a little bit more time for some more of the viewers to join, and then we will get started with our webinar.
Hi there, Karen. You can hear me?
Yes, I can hear you. And
Fantastic. Okay, so we've have we got a lot of people waiting to come in?
so far we have 52 that have joined, and we just there were over 300 registered. So I don't know if we want to allow another minute or two for people to join before we start.
Well, I think the people that have joined us on time, and we must appreciate them by starting on time.
Perfect. Cool. I'm going to get started. So welcome to everyone. Thank you for joining us today for our webinar where we are going to talk about fibroids and a new minimally invasive treatment option for you. So let's talk fibroids and uterine artery embolization. What are fibroids? Fibroids are benign growths that develop in the womb. They consist of smooth muscle and fibrous connective tissue. They are also known as myomas or leiomyomas or even fibromyomas. And these are just some of the other terms used to describe them. Where do fibroids grow? So fibroids can grow in different positions of the uterus, and depending on where they grow, they cause different symptoms. So they can grow within the wall of the uterus, and these are known as intramural fibroids. And these fibroids usually contribute to your bulk-related symptoms. So the uterus being much larger than what it normally would be. And then you get fibroids that are submucosal. So these fibroids grow close to the lining or the middle of the uterus. And these are often the fibroids that cause your heavy bleeding and also problems with fertility. You then also get subserosal fibroids, and these grow towards the outer aspect of the uterus. And these can also cause pressure symptoms, so pushing on other organs that are close to the uterus, like your bladder or your bowel. And then you get pedunculated fibroids. So pedunculated fibroids are fibroids that are growing on a little stalk, and they can either protrude into the cavity of the uterus, and then we would call it a pedunculated submucosal fibroid, or they can protrude to the outer aspect of the uterus, and that would be a pedunculated subserosal fibroid. So your pedunculated fibroids, again, if it's protruding into the cavity, it can cause problems with fertility and heavy bleeding. And if it's protruding to the outside of the uterus, it's more likely to cause symptoms by pressing on organs that are close to the uterus. So more your pressure-related symptoms. Okay, and what are the symptoms of fibroids? Now, a lot of the time, ladies do not have any symptoms, so they're asymptomatic. They're not aware that they have them, but it can commonly cause back and pelvic pain as well as abdominal pain. It may even cause a large abdominal mass. So if you have a lot of fibroids that are growing within the muscle of the uterus and that are quite big, they're going to give you those bulk symptoms and give you this large abdominal mass. Perhaps you have even been asked if you're expecting because your uterus has enlarged so much. This is possibly due to fibroids. They can cause excessively heavy and very painful periods, and this can result in you becoming anemic. And so initially you might think, okay, you have heavy periods, but maybe your other worrisome symptoms are being very tired, short of breath with minimal exertion. Maybe you feel your heart racing even when you're just sitting down and not doing anything tiring. They can also cause pain during intercourse and constipation and bloating. So the fibroids that are more towards the outside of the uterus could press on your bowel or your intestines, and this can cause you to be constipated and have bloating. Or they could protrude forward and press on your bladder, which will result in you needing to wee more frequently than usual. Sometimes ladies even report that they need to get up numerous times throughout the evening to pass urine. And then fibroids can affect fertility and pregnancy. So they might, if they're growing towards the middle of the uterus into the cavity, it can affect implantation. Ladies might suffer from recurrent miscarriages because of this. And then during pregnancy, so if you do manage to fall pregnant with them, your fibroids can actually grow really quickly during pregnancy and can cause significant pain then or even bleeding during the pregnancy. So what causes fibroids? So it's caused by hormones. So every month when you have your menstrual cycle, your estrogen and progesterone levels rise and drop. Now, the rise in estrogen can stimulate the fibroids to grow. And then a family history is also very important. So if your mom, your granny, your sister, your aunt, if they all have fibroids, it's very likely that you may have fibroids too. And then pregnancy can also cause them to grow and to grow rapidly. Who's at risk of developing fibroids? So the older you get, the higher risk you have. Ladies over the age of 30 years. In fact, 20 to 40% of women over the age of 35 would have fibroids. Again, family history and pregnancy. If you're of African or even Caribbean descent, you have a higher risk of developing fibroids. And if you're overweight. So when you're overweight, the excess fat tissue that you carry produces excess estrogen, and then these higher levels of estrogen would feed the fibroids. Okay, and so how are fibroids diagnosed? So it's often an incidental finding. For example, if you've had symptoms of anemia, where you've been very tired, heart racing, short of breath, and you go and visit your GP. Your GP takes a history, finds out that you've got heavy periods, sends you for an ultrasound, and then we find that actually the cause of all your problems are fibroids. That's what an incidental finding would be. Perhaps you present to the emergency department with severe lower abdominal pain. They send you for a scan to figure out what's going on, and then we see you have fibroids. And they are diagnosed by using something like an ultrasound. Now, most ladies would have had an ultrasound, and that's how they found out they have fibroids. It's a scan that's easily accessible, and it's relatively low cost compared to the other imaging modalities that we have. And so most women would have had an ultrasound that confirms they have fibroids. And then once that's confirmed, as radiologists, we like to send you for an MRI. And the reason we choose to do the MRI is it is very good at detecting all the fibroids. We can see exactly where they're located, their size, and we can look for other problems which may also cause symptoms similar to symptoms that are caused by fibroids. Now, what are the treatment options? So you can take medications to help treat fibroids. Some of the commonly used medications would be the combined oral contraceptive pill. You could use something like an intrauterine contraceptive device like the Mirena. It's got a small little bit of hormones in it. It's inserted into the uterus, and then the hormones given off either stunt the growth of the fibroids, or they help to thin the lining of your endometrium so you don't have the heavy bleeding associated with having the fibroids. And then there are other medications like vitamin D is actually proven to slow the growth of fibroids. And then sometimes medications are prescribed not so much to treat the fibroids, but to help you manage the symptoms. So something to stop the heavy bleeding. It's known as tranexamic acid, or maybe Tranic, or cyclic capron, or the more common names used. These are help to manage the bleeding during your period so that you don't become too anemic. Other options are surgery. So with surgery, you can either have individual fibroids removed. This is known as a myomectomy. Or you could have a hysterectomy, and this is where they remove the entire womb. And then the other options are your minimally invasive treatment options. So there is something, a high intensity frequency ultrasound, but it has limitations. It can't be used to treat all fibroids, and it's also not readily available. As far as I know, there is really one place in the country where you can have it done, and that's at Baragwanath. And then there is the uterine artery embolization. Okay, so let's talk about the uterine artery embolization. Who should consider having one? So if you're a young patient when you're diagnosed with fibroids, and that's because if they are surgically removed, the rate of them growing back is quite high. And you would only be able to have a certain number of surgeries in your lifetime. And so if you get them when you're younger, if you start having surgery at a young age, you're going to run out of options before you hit menopause and your fibroids stop growing. It's also appropriate for ladies who perhaps do not want to have surgery. And especially if you've got numerous fibroids and your option of surgery is really to only have a hysterectomy. Perhaps you still want to explore the possibility of having children, and without a womb, that's not possible. But at least if you consider having a uterine artery embolization, you can keep your womb, treat your fibroids, and then look at potentially having children. It's also appropriate to consider having one when other treatment options have failed. Perhaps you've tried the medications and tried surgery, and yet they keep coming back. And then it's also good to use it in patients who are high risk. So patients who are high risk either for a general anesthetic, then they could consider having a uterine artery embolization, or ladies who are high risk for having major surgery. So when is it best to perform a uterine artery embolization? So when you're symptomatic of your fibroids, that's a good time to look at having treatment done. Another condition that can be treated using a uterine artery embolization is perhaps you're diagnosed with adenomyosis. So what adenomyosis is each month when a lady has her period, you would usually shed the lining of your uterus. This is known as your endometrium. But in some ladies, what's happening is the endometrial cells are implanting back into the muscle of the uterus. And so each month when you have your period, you bleed into your muscle of your uterus. And this usually causes extremely painful and very heavy periods. Unfortunately, we are able to treat adenomyosis with a uterine artery embolization. It can also be used for dysfunctional uterine bleeding. And sometimes we do it before surgery. So perhaps you have a really large fibroid that's pedunculated. So that's the fibroid growing on the stalk. And with our procedure, yes, it is going to shrink, but perhaps you need more reduction in size than that. And so the plan is to have it removed. So we could do the embolization before your surgery. And the reason we would want to do this is if you had the surgery without the embolization, you could lose up to, for example, 800 milliliters of blood. But if we did the procedure for you before having the surgery, you would lose approximately half the amount of blood. So perhaps only 400 milliliters of blood. It can also be used for ladies who've sustained a uterine injury. So perhaps you're involved in a major accident, there's damage to your uterus, it's bleeding profusely, they can't stop the bleed. If we go and embolize that artery, so cut the blood supply off, we can save your life and we can save your uterus. It can also be used in the postpartum setting. So that's once a lady's given birth. Some ladies continue to bleed after birth. Sometimes we can identify a cause, but it's still difficult to stop the bleeding. We can go in and do the embolization, again, stop the bleeding, get it under control, save your life and save your womb. And then it's also used in a palliative environment. So if patients perhaps have end-stage uterine cancer and they're bleeding or they have a lot of pain, we can do the embolization to help control those symptoms and just provide them a little bit of relief. So how do you book a uterine artery embolization? So step one is to find an interventional radiologist, and that would be someone like Dr. Gary Sudwitz. We at the microsurgery have been doing this procedure for many years. Dr. Gary has the most experience, certainly in South Africa. And so you would need to find an interventional radiologist to perform the procedure for you. We would then refer you to a gynecologist if you had not yet seen one. And the reason you need to go and see a gynecologist is the gynecologist is going to do a general exam as well as a pelvic exam and is going to rule out other causes of your symptoms. So we don't want to just attribute your lower back pain to fibroids. We want to make sure that there isn't something else causing your symptoms. We also need to rule out any underlying malignancies or cancers. So make sure that we're just treating fibroids and not something else. And the gynae will do an ultrasound for you. And then we will send you for some blood tests and then do the MRI. So you're going to have 2 scans. One is going to be an ultrasound and one is going to be an MRI. And then you will be admitted to hospital and you'll meet your team. So what are the benefits of having a uterine artery embolization? So it's minimally invasive. We don't cut anywhere and we don't put stitches in. We do everything through a little hole in your wrist. It's done under sedation. So what this means is when we go to theater, we don't give you a general anesthetic. You're breathing on your own. You're just having a really good sleep. It has less complications. So for example, a hysterectomy would have a complication rate in and around 14%, whereas the complication rate of a uterine artery embolization is around a hysterectomy is 14% and a uterine artery embolization is 4%. So it's a lot less. It is a shorter hospital stay because it is so minimally invasive. You have no scar and you've got a quicker recovery time. So let's have a look. How is a uterine artery embolization performed? So you have your deep sedation. So this is the part where you meet your anesthetist, they give you some medication and you have a great sleep. You don't feel any pain and you're not going to be aware of us doing the procedure. We then use an ultrasound on your wrist. So if you can see my wrist, on your wrist, if you feel below your thumb, you can feel your pulse there. That's the artery that we use. It's known as the radial artery. We use an ultrasound to locate that artery. We put a needle in, and then from there, we start to advance catheters and wires. So a catheter is a long, flexible plastic tube. We pass it through the blood vessel in your arm. It joins up with the main blood vessel in your chest. And as you can see, we use real-time imaging to do this. So it joins up with the main blood vessel in your chest, known as your aorta. This then travels down the abdomen and it gives off a branch in your pelvis, one on the right to the uterus and one on the left to the uterus. And that's where we find the uterine arteries. Once we have advanced the catheter into the artery, and we're sure that this artery is only supplying blood to the uterus and the fibroids, we then start with embolization. So inside this little syringe, there are thousands of tiny little particles. They're like tiny, perfectly formed beads. And we then inject these little particles. They travel along the uterine artery and into the smaller arteries that supply the fibroids in the uterus, and then they block off the blood supply. Your fibroids are then starved of oxygen and nutrients, and they die, and they shrink. This process of the fibroids dying can cause quite a lot of pain. So at this point in time, we do a nerve block for you. We take a long needle, we put it below your belly button, and we just insert the needle there, and we inject some local anesthetic, and this blocks the nerve supply to the uterus, and it helps for pain management after the procedure. Once we've done this, we then remove all the catheters and the wires. So these are the long, thin plastic tubes. And then we apply a little compression device to your wrist. It's a little plastic band that goes on your arm. It's got a pocket that we can fill with air with a syringe. It then presses on that area where we put the needle in. And then over the next few hours after you've woken up from the procedure, the air is just slowly taken out and the band is removed, usually the same day of the procedure. And then you get to take your life back. And what does this look like for you? So what we ask is, give us 1 hour, we will do the procedure for you. Spend 1 day in the hospital after the procedure, 1 week for recovery, and then going back to work and even doing things like exercise, and 1 month. After 1 month, you're going to have a period and you're going to see it's normal. You're going to be able to experience what a normal period is for you. You're not going to have this dreaded fear that when you leave the house, you're going to leak on your clothes. You'll be able to attend parties, work meetings with confidence that you're not going to be embarrassed. And that's how you get your life back. So we're going to have a quick Q&A with Dr. Gary Sudwitz. I don't know, Gary, if you want to start by answering some of the questions that have possibly been answered while I've been talking.
Yeah, thanks, Karen. Forgive me, everybody, my voice has changed after some whooping cough, but I hope you can hear me and it doesn't sound too ridiculous. Thank you for everybody's input, and I've noted your questions, and please keep them coming. I want to try and answer them as we go. Just before I do that, I just want to mention the whole thing about Women in White. What this is an initiative by us to really make women aware of the condition of fibroids and how it affects their lives. And what it basically means is our patients can't wear white because their lives are impacted so much by fibroids. And it seems like a very superficial, silly thing, to not have a color in the wardrobe. But fundamentally, it's a freedom, and the way one's life is changed by uncontrolled bleeding. And that's what we're trying to change. So what happens often is that women come to us and say, why didn't I hear about this earlier? Why didn't I know? And this is our actual way of helping women to understand their options. So thank you for attending. Thank you for giving us your time, your lunch break or your hour. And thank you to the team for putting this together. So just to get to the questions, something that comes up quite often is the cost of the procedure. Now, it is expensive. The bottom line is it's covered by medical aids in South Africa, which was largely due to our work. When we started, most medical aids didn't fund it, and now almost all medical aids do. And it's really not just because of us, because there's such a massive demand from clients of the medical aid, patients within the medical aid, or people that they know that there's such a huge public health issue. Practically half of women in South Africa have fibroids, and half of them need some sort of treatment. So really, it is important. It is funded by the medical aids. This procedure, as well as myomectomy or other procedures, are covered by medical aids. The fibroids are, in fact, prescribed minimum benefits of PMB that the government has determined has to be funded by medical aids. But the reality is a large number of women, that's probably 90% of South Africa, don't have medical aid, and therefore their options are much more limited. So the answer in terms of cost, if you put an absolute number on it, it's in excess. When you add, all the other things like MRIs and gynaes, etc., to it, probably over 100,000 rands. As I said, that is covered by the medical aids, but public health, there is limited access to the procedure. To answer the question about PCOS, so polycystic ovarian syndrome, or PCOS, is a completely different condition, hormonal condition affecting the ovaries, and is not impacted by this procedure. However, the problem is that PCOS and endometriosis and fibroids and adenomyosis, they all have very similar symptom profiles, so that patients who have one condition can have the others, or some of the others, and sometimes they're told they have one, yet they have others, and it's very hard for the symptoms, which may be pain or bleeding, or that, to tell one from the other. That's really where the doctors come in, and the test that we do to try and distinguish that. But it can be very confusing from a patient's perspective. But the short answer is no, this doesn't treat PCOS. Regarding shrinkage of the fibroids, so this is where a few ladies have brought this up in our chat group, where they've either had a previous myomectomy or rather embolization. They've gone back to the gynae, and the fibroids, they say, are back, or still there. I just want to be clear on one's expectations. So if you've got a large fibroid, there's really no limit to the size of fibroid you can embolize. The problem is the large fibroid will only shrink a certain amount because we don't actually take out the tissue. We kill the fibroid, but the fibroid remains as scarce and tissues is still there. So what we expect is about half shrinkage after about a year. So if it was 8 centimeters, it goes down to 4 centimeters. But what I try and tell patients is that the point is not to get rid of the fibroid. That's why they come. They come because they want the fibroid gone. Actually, the point is to get rid of the symptoms, the mass, the pain, the bleeding. That's what we're trying to get rid of, not the fibroid. So if a 4 centimeter fibroid remains and it's not causing any issues, well, that I think is a win. So the short answer is the fibroids do not disappear. They shrink by about half. And in 90+% of women, that's more than enough for them to be really happy with the procedure and to be happy with the results. Sorry, Karen, can you hear me? Am I loud enough?
Yeah, I can hear you.
Thank you. So, can I answer the question? If a fibroid is growing after embolization, well, then it hasn't been sufficiently killed. It shouldn't grow at all. It should shrink. And therefore, then the question would be, well, maybe there's still blood going to that fibroid, and it would need a repeat procedure of some description. So that kind of answers that. Regarding can you just search if you had a C-section? The answer is yes. It makes no difference. Many patients have had previous surgeries and they go on to have embolization. And then I had a procedure for an olocolo in East London 3 years ago. They came back. Okay, so I'd be happy to see you again. And the way to really distinguish if they are still growing or still getting blood is to do another scan, which is an MRI scan, but with contrast. And that very quickly can determine if there's blood going to the fibroids, if they're sufficiently embolized, and if they have grown since the previous procedure. It is sure that sometimes, thank you, Anna, just got some water, that sometimes the fibroids do continue to get blood supply. I think we must understand that if we got a perfect result, that means 100% of fibroids are dead 100% of the time. We'd also have increased complications. There's a certain amount of aggression that is needed, and then there's a point when we mustn't cause harm, and we can't take back the embolic material. So I think it's important to say that no procedure in medicine is without complication, and there is a recurrence rate. And regarding hysterectomy, unfortunately, we can't, once we have hysterectomy, we don't do embolization, but menopause, well, that does depend. Menopause does not come after hysterectomy. Hysterectomy is removing the womb. Menopause would happen if you removed the ovaries. The ovaries create the hormones, the female hormones that are reduced in menopause. So menopause is independent of the hysterectomy. Menopause usually happens around the age of 52 in America. We don't really know the age in South Africa, but it can take, it does vary a lot. Lindiwe had embolization in September and saw gynae fibroids still the same, not shrinking. I think really, Lindiwe, we would need to compare the new MRI with your previous one, and then we can determine if there might be a cause. And then Patricia had babies and she had surgery in 2009, then had kids, but now they're back with endometriosis. Okay, so I think fantastic. You had kids. That's a great result. The question is endometriosis, PCOS, as I mentioned, and then adenomyosis, which is basically endometriosis in the uterus. These all crossover conditions. So I think, how do you proceed from here? Well, I would get you to one of the gynaes we work with, and you'd probably land up with an MRI. Tracy, fibroids small, not causing you pains. Gynae advised leave them alone. They need to do was remove the cyst. That's probably very good advice. So most patients don't need surgery. They don't need an intervention. They have fibroids. They live the fibroids. They don't cause an issue. Leave them alone. That's good advice. In patients and in symptoms, that would be a justification for us to do something. Can you get pregnant, Libra, after embolization? Yes, that's quite right. You can get pregnant after embolization. We have many babies that patients were advised they wouldn't get pregnant or shouldn't have embolization, and that's not true. Lily and Monchi, I had a uterine embolization by myself in August. That was last month. Significant reduction. Thank you, Lily, for that vote of confidence. I'm not sure whether it's my new life. You can be confident. I promised you your life would change, and it has changed. And I'm glad you're happy. Azulpa, are there any side effects after the procedure? Well, side effects, I'm not sure if you mean side effects or complications. I presume that's complications, and there are. These are things that can happen after. And I think just summarizes that when you go for a procedure, this is not a game. It's not a walk in the park. Things can happen. Things can go wrong. And they can be very serious. So you're really sitting in a situation where you're choosing to do something that may result in harm, and you'd only do it because you have to. And in that stage, you'd say, what is the least invasive option with the safest option and the best outcome? And that's really our job to try and advise. So the answer is yes, there are complications. Our rate is between 1% and 2%. That's my own personal rate in my practice. So we check all the patients that have complications, write them down, and that's far lower than the rate of complication after myomectomy or hysterectomy, and that depends on those individual doctors tell you what their rate is. That's reported in American literature at around 12 to 14%. So I just pointed out as a safe procedure. Excuse me. We've discussed the cost. So just to mention, this webinar is recorded and would be available to you if you wanted it. If you missed an answer or got in a little late, we're happy to share that with you. Dr. Ken, thank you for the presentation. Emotion. There you go, Karen. A lovely vote from Lillian.
Thank you.
Rosanna, I procedure February. Thank you, Rosanna. Thank you for the confidence. Okay, Dr. Karen. All right. How to get a fibroid measured? So the measurement after the most accurate way to measure fibroids is by MRI. Can we have a session regarding unblocking fallopian tubes? Yes, we certainly should have one of those. We've started to do that about 2.5 years ago. We've had a lot of tubes unblocked. It's very specific. Not all tubes can be unblocked, as it's a condition for really tubes that are blocked that are not damaged by some previous disease. But we will do an educational on that. Save version, yes, absolutely. We'll make that available. So we're getting to about 35 minutes into the presentation, mindful of everyone's time. So really the plan is just an attempt at awareness that we're educating people. We're available to our patients and really to the wider public to share our knowledge and what we're doing, and that this impact goes further, because Even though there's limited access to this procedure in the public sector, it is available. We are teaching doctors to do the procedure. We're motivating funders to fund the procedure, whether it be government or the private sector through the medical aids. And then your general awareness would become advocates for the procedure as mothers and sisters. You share your information, and I'm very much aware that as a old white doctor, my impact is very limited, and women talk to each other and share knowledge with each other and trust each other, and therefore this is really your way of sharing your knowledge too. Um, just a few more questions. Gynecologist says fibroids in the wall of the uterus. Yes, fibroids can be in the wall or outside the wall or in the cavity. It depends on where they lie. Can we get in touch with additional questions? Yes, absolutely. Our details are there. Info at fibroids or info at the microsurgery. We'd be very happy to chat to you and help you through your process. Does it affect me getting pregnant? Yes. Fibroids are a major cause of infertility. It depends on the and the location and size of the fibroids. However, they're not the only cause. So having fibroids doesn't mean you're not going to have babies. And treating fibroids doesn't necessarily result in fertility. It's a little bit more complicated than that. But the short answer is yes, fibroids can affect your fertility. So can it's possible to have your after having your tubes tied? Absolutely. So many women have had babies, they've had the tubes tied, they've got fibroids causing major issues. Yes, absolutely. One could do an embolization. Is it mostly African women? Very good question. That's Landiwe. The answer is there's a much higher incidence of fibroids in African women, particularly women of West African descent. Now, our Southern African women aren't from West Africa, but we certainly have a very high instance of fibroids in South Africa. And not only are there a lot of women with fibroids, but with the fibroids seem to grow quicker, they come back quicker, they cause more issues in Black African women. So the answer, unfortunately, is yes. There must be, of course, be a genetic factor that relates to race in this condition. We haven't yet, as scientists, figured out exactly what it is. Only to say Black African women are of higher risk regarding fibroids. How long does it take fibroids to shrink? Had a UFU in February. So I think, Safakila, you should notice by now that the fibroids have shrunk. Your tummy should be flatter, or you should have, it should feel like there's more space. Your bladder can feel better. Certainly after 6 months, you've noticed it, and they'll continue to shrink even up to 2 years. But again, don't expect them to disappear. They're not going to disappear. But they'll shrink a lot, enough for that, that you should be happy. That would be my expectation. So I think we're going to go for some last questions because we're getting to 40 minutes. I don't want to keep everybody. As I say, this presentation will be available. People have only managed to join us recently, so the information will be shared with them. And certainly you can ask us any questions on those contact details attached. Our staff also are very knowledgeable and very willing to share the information.
So just to let the ladies also know that the video is also available on YouTube. And then I will also download the chat, and I can try and answer some more of the questions on the chat. And then once that's done, I can download it, and everyone who has registered will get a summary emailed to them of the information shared today.
And just to mention, Karen, we've got how many people have attended? Over 100?
Yeah, I think at one stage we were 110.
Fantastic. So we've reached out to a lot of people today, and a lot more will have access to this information in the future. So thank you all for participating, being part of this with us. Any further comments, Karen?
No, I think that's all.
Wonderful. Thanks for your efforts.
Okay, pleasure. Take care, everyone.
Bye-bye.
Bye-bye.